This lecture provides an overview of brain tumors. All tumors arising within the cranial cavity are called brain tumors. It is convenient to group brain tumors into intraaxial tumors, which are within the substance of the brain, and extraaxial tumors, which are within the cranial cavity but outside the substance of the brain. Intraaxial tumors may be primary or secondary. Among the primary intraaxial tumors, gliomas arising from glial or supporting cells are the commonest. Astrocytomas arising from astrocytes range in malignancy from grade 1, which are benign, usually found in children. Classically, pilocytic astrocytoma is a representative. Grade 2 tumors are low-grade gliomas found in adults. Grade 3 tumors are anaplastic astrocytomas, and grade 4 tumors are very highly malignant glioblastoma, earlier called glioblastoma multiforme. The new WHO grading has upended the malignancy grading of tumors, and the emphasis has shifted from histology to molecular markers. Other glial tumors include oligodendrogliomas. By molecular markers, they are defined as IDH mutant and 1p19q deleted. Ependinomas, they arise from the fourth ventricle and may extend into the CP angle, can be found in other locations also. Medulloblastomas, bimodal peak, but more common in children, arise from the roof of the fourth ventricle. Primary CNS lymphomas and brainstem gliomas are also intraaxial tumors. Secondary intraaxial brain tumors are tumors which have metastasized to the brain. Common sites of primary include lung cancer, cancers of the GI tract, breast cancer, prostate cancer, and melanomas. There are some secondary tumors which might bleed spontaneously. These include melanomas, renal cell carcinomas, the hypernephroma, hepatobiliary tumors, choriocarcinomas, and follicular cancer of the thyroid. Now, malignant tumors of the brain have certain, whether primary or secondary, have certain imaging characteristics. They usually enhance with contrast, and sometimes the enhancement might be more in the periphery, reflecting internal necrosis and poor blood supply to the core of the tumor. So they're called ring-enhancing lesions. The differential diagnosis of a ring-enhancing lesion would be a glioblastoma, a metastasis, a tuberculoma, an abscess, or a lymphoma. Malignant brain tumors also have significant peritumoral edema. There is edema around the tumor. The etiopathogenesis of peritumoral edema is new vessel formation, and these new vessels or neovascularization lacks a blood-brain barrier. Amongst the extraaxial brain tumors, that is tumors which are intracranial but outside the brain substance, meningiomas are the commonest. Meningiomas are good tumors to have because 90% of meningiomas are benign, grade 1. The cell of origin of a meningioma is from what are called arachnoid cap cells arising from the arachnoid. It is convenient to group meningiomas depending upon their location. You have calvarial meningiomas, which arise from the dome, and you have skull base meningiomas, which arise from the skull base. Calvarial meningiomas include convexity meningiomas, parasagittal meningiomas, that is, a tumor close to the sagittal sinus and impinging upon its walls. Meningiomas arising from the dural folds, that is, the fox cerebri and the tentorium, can also be considered as calvarial. Skull-base meningiomas include anterior cranial fossa meningiomas, classically olfactory blue meningiomas, tuberculum sellae meningiomas. Sphenoid wing meningiomas may be lateral, in which case they are sometimes called pterional, alar, or they can be medial or clinoidal. We also have posterior fossa meningiomas, cerebellopontine angle meningiomas, clival meningiomas, petrous and petrous apex meningiomas, and foramen magnum meningiomas. Another group of extra-axial brain tumors are the schwannomas, which arise from the cranial nerves. Any cranial nerve can give rise to a schwannoma, but they are particularly common in two nerves. One is the vestibular schwannoma, and the other is a trigeminal schwannoma. Vestibular schwannoma, sometimes incorrectly called acoustic neuroma, arises from the vestibular branch. Vestibular schwannomas can produce clinical symptoms because of involvement of the vestibular nerve, that is vertigo. It can involve the acoustic component, in which case initially you get tinnitus and later you can have hearing loss. Impingement of a vestibular schwannoma on the trigeminal nerve, especially if there is a vessel trapped in between, sometimes produces trigeminal neuralgia. The facial nerve is adjacent to the eighth nerve, but facial weakness is not very common. Lower cranial nerves can also be affected, inducing dysphagia, dysphonia, and nasal regurgitation. Vestibular schwannomas, when they become larger in size, can produce a cerebellar syndrome because of pressure on the cerebellar hemisphere. As it grows larger, it can distort the brainstem, producing brainstem compromise, which can range from motor manifestations because of long track involvement to respiratory difficulties. Hydrocephalus can also occur because of vestibular schwannomas when they distort the fourth ventricle and the CSF outflow pathways of the fourth ventricle. Yet another group of extra-axial intracranial brain tumors are pituitary adenomas and pineal tumors. Pituitary adenomas may be microadenomas, less than 1 centimeter, in which case they are usually confined to the cella. Or they can be macroadenomas, which are larger tumors. Pituitary adenomas are classified into functioning adenomas and non-functioning adenomas. Functioning pituitary adenomas include growth hormone producing adenomas, which can result in gigantism in young and acromegaly in adults. ACTH producing tumors will produce Cushing's syndrome. Prolactin producing tumors can result in Froelich Albright syndrome, which is also called the amenorrhea galactorrhea syndrome. TSH producing tumors are rare. Non-functional pituitary tumors produce symptoms because of their growth trajectory and mass effect. Chiasmal syndrome is common, where a patient can have bitemporal hemianopsia because of compression on the crossing fibers of the optic chiasm. Hydrocephalus can occur because of compression and distortion of the third ventricle. Aggressive tumors invade the cavernous sinus and can produce oculomotor palsies. An acute presentation of a pituitary adenoma can occur in the form of pituitary apoplexy, where a bleed into the tumor results in a sudden increase in size, producing visual impairment, oculomotor palsies, headache, and often panhypopituitarism. Pineal tumors can produce headache, gaze palsies, and seizures. Headache is often because of hydrocephalus, because of pressure on the aqueduct. Initially, brain tumors can present with increased intracranial pressure. They can produce seizures or they can produce focal deficits. Increased intracranial pressure occurs because of the Monroe-Kelly doctrine, which states that the cranium in an adult is a fixed volume cavity. Any increase in the volume of contents intracranially will result in an increase in intracranial pressure, and an increase in intracranial pressure will impair the cerebral perfusion pressure. By the equation, mean arterial pressure, that is MAP, minus intracranial pressure, which is ICP, is the cerebral perfusion pressure. So the tumor mass itself adds on to intracranial volume. So a large tumor produces increased ICP because of its mass, because of its volume. However, initially this is compensated because CSF gets displaced. The second cause of increased intracranial pressure is edema, what is called PTE or peritumoral edema. Peritumoral edema is a manifestation of neovascularization, and hence usually it happens in malignant tumors. ICP can occur, ICP rises can occur rapidly with hydrocephalus when the CSF pathways get blocked. Children with posterior fossa tumors often present with a crisis because of hydrocephalus. A bleed into a tumor can also result in an increase in intracranial pressure. Increased intracranial pressure manifests with headache, vomits, visual blurring, which might be a feature of papilledema, and later there can be loss of vision. Seizures occur with brain tumors. They are usually focal with secondary generalization, and sometimes these seizures are associated with Todd's palsy, that is, from the area where the tumor exists and the seizure originated, the motor component is impaired in function for 24 to 48 hours. So if you have a right-sided tumor involving the motor strip giving rise to a seizure, you can have left-sided weakness, which can persist for a day or two. Focal regional syndromes can occur with brain tumors. We have frontal lobe syndromes with personality changes, sometimes with disinhibition, sometimes with aggression. Aphasia, dysphasia syndromes can occur, especially in left-sided tumors affecting the speech areas. Motor syndromes occur, and visual syndromes can occur when the visual pathways are impaired or the occipital cortex is affected. Once a brain tumor is suspected, some variety of imaging is done. CT scans of the brain are often the primary investigation. A non-contrast CT, that is before giving contrast, will show us bleeding. It will show us calcification. After administration of contrast, we find that a tumor enhances. That means that there is new vessel formation and potentially malignancy. CT is especially useful to identify bone changes. You can have hyperostosis or you can have bone destruction. Bone changes are important for surgical planning. MRI brain is the imaging investigation of choice. We have T1 weighted sequences which will define the tumor. An addition of gadolinium, a paramagnetic substance, which is a contrast material, will show us enhancement when the blood-brain barrier is broken. T2 weighted sequences show CSF as white. There is an advantage here because the vessels are very well sealed, so vascular relationships can be identified. FLAIR, fluid attenuation images, help to identify brain edema. MR spectrography can show you choline peaks or lactate peaks, which indicate the type of an intracranial lesion. Tractography is a rapidly evolving new modality. It depends on the phenomenon of fractional anisotropy, and it can show the tracts. This is important for surgical planning because the involvement of the or transecting a tract will result in major deficits. Functional MRI helps us to identify areas of eloquent cortex. Pre-surgical management of a brain tumor involves anti-edema measures. We give dexamethasone, we give mannitol,